name's Josh Landy, and I'm a critical care physician, but I'm also one of the co-founders of this company called TriggerOne. So I'm going to start by telling you about a guy named Hugo Inigo who works in the Peruvian rainforest. And every morning, Hugo gets up, gets on his motorcycle, and drives from outside the jungle into the jungle to look after a group of 2,000 people. And when he sees people there, he has to appreciate whether or not they need advanced medical care. So if they need something more than he can offer, if they maybe need surgery, that means that they need to get on a plane 3 times until they get to Lima and potentially exhaust not only all of their own resources, but potentially some of the village's resources as well. This sounds like it's just a global health problem, just a small one, and it is. But it's also not, because you don't need to be in the Peruvian rainforest to be alone, right? As a physician, I know that you can be alone anywhere. And this is really hard, especially if you're in a busy tertiary care hospital where there's thousands of patients coming in and out. And you're there, and it's 4 in the morning, and there's almost nobody else to talk to. If you have a complicated case and you need to run it by somebody, unless you have a specific question to wake somebody up to ask them, you won't necessarily be able to connect with somebody. And that's the existential dread of medicine, isn't it? To be able to stand next to a patient and know that you need to help them, but you can't because you don't have the knowledge you need in the moment you need it. And this doesn't make any sense really anymore, because now we live in an age where we're all connected. We're all connected with phones, and we use them all the time. We've learned all of these social behaviors that we use in the rest of our lives. We use them to connect around all sorts of topics. But these ideas of using social tools to connect inside medicine is a very nascent field. So I was thinking about this when I was here doing research a few years ago in the great department of anesthesia, and we were learning about what young physicians are doing with their smartphones when they see patients. The answer is basically they do lots of stuff, but mostly the way they do lots of stuff is by taking pictures of cases and sending them around for conversation and discussion. This makes sense. This is a behavior that I recognize in my colleagues as well. It's not particularly safe from a privacy perspective, but it accomplishes a task. If you want proof of this working, just ask any doctor to see their phone and look through their photos. You're not going to be disappointed. So the idea came to build this network. We called it TriggerOne. And what the network does is it lets you take a picture of a case, add a caption, and submit it for conversation, discovery, for learning, for teaching, and for any other reason why you might need to take care and might need to take a picture of a case. So if it's something you've never seen before and you want to record it, you take a picture. If it's something you need help with, you take a picture. If it's something you need to share or teach, you take a picture. So today I'm going to talk to you about the opportunities and challenges of connecting 1 million healthcare professionals using this type of network, and how we designed this platform using design thinking to design it so that anybody could use it, design it so that everybody can use it, and design it so that it works in the reality of healthcare. So I'm going to talk about why first you need to design for all healthcare professionals, and that includes Dr. Hugo, who works in the rainforest. And so the idea was that he is a TriggerOne user, and now he can take his idea and he can put it up and he can ask now up to 1 million healthcare professionals, what do you guys think? Is this the right move? Does this patient need to be transferred, or is there another disease that I should look up first before I put them on a plane? This is incredibly useful, not just for him, but for everyone else in the 190 countries where the app is available. It's not just, though, about the breadth, right? It's about depth, being able to get all the different types of information. And that's why we are including as many healthcare profession types as possible. This is TriggerOne's version of everyone included, bringing every type of medical specialty that is out there onto our platform. Because if you need information, it doesn't matter if you're a dermatologist in California or you're a medical librarian in Nepal. If you have information that somebody can use, you want them to have access to that information in the moment they need it too. And what that means is we're no longer restricted. We're no longer restricted by borders, by boundaries, by cities, states. We're not even restricted between hospitals, which sometimes are the hardest boundaries to cross. Anyone who's worked in a large hospital across the street from another large hospital knows how difficult it is to get information across the street, let alone patients, and let alone having providers come across the street to do a consult. That's incredibly challenging. And so what we've tried to do is create a system where knowledge can be transmitted no matter where you are. And that means that everybody has equal footing. It means that they've got, no matter if you're the chief of physicians of Mount Sinai Hospital, who's a Figure One user, he's a cardiologist, or if you're a third-year medical student, or if it's your first day of med school. Now, obviously, you want to be able to know whether you're talking to a first-year med student or a graduate cardiologist. And that's one of the challenges that we've faced, and essentially, all you have to do is tell people who you are. We do this with our verification network, which now verifies physicians in over 100 countries and is the largest verification network in the world. So how do we design for everybody? Now, if you're connecting healthcare today, you need to be able to design with everybody in mind. And what that means is thinking about distribution. So let's look briefly at this distribution curve. So this is the way things are distributed, consumer goods and so forth. I'm going to talk about record sales because I like music. So if you chart this by number of sales versus where you are on the charts, the people in the top 20 albums are going to sell way more records than anyone in the long tail, right? So for example, Beyonce's Lemonade debuted at #1 on the Billboard 200, sold 485,000 copies in its first week. And so she belongs way up there. But compare that to an obscure German pop band that I like called Wolfpack, and they go down here, and maybe a little further. Right? You can go in and you can ask somebody. I wouldn't want to go into a Tower Records and say, do you have Wolfpack's Fugue State album? Because that's like way down here, Japanese import only. It'd take a couple weeks to get in. But that's no longer true, right? I don't go to HMV or Tower Records anymore to get my music, right? Use Apple Music and Spotify and Amazon and everything else, because what that does is it takes the long tail of the curve and it does this. And it makes these two things just as easy to find. All you have to do is locate the search bar, type in the name of the thing, and one thing is immediately as available to find as the next. So how do we take this thinking and apply it to healthcare? Well, the idea is that if there's knowledge that somebody possesses that they have and you don't, you want to be able to immediately access that simply by typing in the name of the thing that you're looking for and being able to access all of the network of healthcare professionals. And this is the idea that sort of links to Stanford Medicine X through the democratization of medical knowledge. We make the knowledge available to everybody through these cases, because that to me is the atomic unit of healthcare, right? When you are seeing a patient in front of you and they have something you need to help them with, that's what you want to help them with. For example, a nurse in Haiti put up a picture of a little baby who she was looking after. It was at a maternity center, and in fact, the nurse was the only healthcare professional in that maternity center. So when this baby was born with an unusual skin condition, she didn't know what it was and if it was safe to let the baby leave. So she put up a picture of it on Figure One. And within a few hours, 16,000 people had come to see it, logged hundreds of responses, and the one that was voted to the top and agreed upon by many of those hundreds was from a pediatrics resident in Vancouver, Canada. So it doesn't matter how far away you are. And what that means is we can change what is the traditional way of a patient accessing medical care. Usually, so this is what happens if you go to a hospital. You go in, you get seen by a number of specialists, and then they pick who the right specialist is for you, and you see that specialist. In the same time that it takes to see one doctor in real life, you can see 50,000 doctors on Figure One. And you can get hundreds of comments showing you what the risks and benefits of various treatments are. You can get an advanced sense of what the prognosis is, what the likely diagnosis is, what further tests need to be done, and what sort of follow-up you need. And the challenge of this, of course, is being able to cross borders with medical care. And for that, I have our lawyer to thank, who dredged through so many layers of healthcare law to be able to say that we can now do this. We've got consent forms for almost every country in the world. And it's in every different, it's in the languages of those countries, so that patients when the doctor hands the phone to the patient's consent form is in their own language. And that's part of designing for real life, realizing that it's hard and it's complicated to be able to do these things. So when people come to see me and they say, hey doc, I got a great tool, it's going to change the way you work, our conversation is over. Because I don't want to change the way I work. I don't want someone coming in and blowing up my workflow. My workflow depends on hundreds of other people in the hospital, and if you change mine, they need to change theirs, and if we're not changing together, details are going to get lost. Right? The system is built for safety and robustness. It's not necessarily built for flexibility and innovation, which is one of the big challenges in healthcare. So that means that we need to create products that are going to let doctors and nurses use them with one hand so their other hand can stay where it needs to be. So that means that tools like this, the consent form and the automatic privacy tools, need to be built in, and they need to be really, really easy for people to use. It's not just a workflow that we design for in healthcare, but also thinking about the way we learn. And this is my sort of central thesis on how this connects to medical education, is that we are learning every time we see a new case. Right? Education and clinical practice are meaningfully connected, and to separate them and put education in a lecture hall and to put clinical practice in a hospital doesn't make any sense to me. These two things happen at the same time. And there's this concept, we learn in healthcare, we learn in spirals. And what that means is you start with a single piece of information. Oh, that's interesting, I didn't know that. Well, I'm going to look that up, and you learn a little bit more. And then you see another case like that, and then you learn a little bit more. And you keep learning until you totally understand it. And that is called spiral learning. And it's the principle behind the old medical adage of see one, do one, teach one. The first time you see it, seeing it for the first time. The next time you're in charge, and the time after that, you're the one teaching the person who's never seen it before. And we see that on figure one. This is an example of a skin condition called erythema ab igni. And erythema ab igni is a skin condition you get from being exposed to infrared radiation. It's not super harmful, and it does go away very quickly, but it looks very striking. And I didn't know what it was when I first saw it on the app, and then somebody explained it to me. And of course, next time I came up, I was like, that's erythema ab igni. I know, of course. It's from infrared radiation. But every time we have one of these cases, the number of views increases, and the number of people who are seeing it and commenting and discussing it increases. And this is the way we take real life and we put it on your phone. And that means that you can reach it. That means that you can get the information you need the moment you need it. And it also means that you can access information that others have given you. Right? It basically creates the largest clinical practice group in the world, or the largest study group in the world. But what that means is that no matter where there is an internet connection, you can have access to the knowledge of specialists. So if you're a nurse very, very far away, all you need to be able to do is describe your patient's case and put up a picture. And that patient can get the same quality of information from other places where they no longer, where they wouldn't have had access to otherwise. And so this is why I mentioned Dr. Hugo Inigo and his place in the Peruvian rainforest, because it's not just for him, but it's for all of us to use and connect together. We're essentially creating, and what we've seen grow out of this, which is now over 1 million healthcare professionals together, is we're creating a community where we all can learn together, and we can essentially drag the practice of medicine into the future. And we can do it together. With that is the end of my presentation. So thank you, and I'd be open to take questions if you have any. 100%. I was going to say drones, but I don't think that's the answer. I think what you're suggesting is probably the right thing to do. No, but I think that's right. And the idea that once you have connections in a place where Hugo works, and you've got connections where there are secondary and tertiary hospitals, you can start a referral network, right? And that's not something that we're doing yet, but it's something that'll certainly come out of this, this community. We're already seeing people who are saying, we specialize in this particular thing, and this is the way we manage these cases. The next step is to take the patients and connect them either directly with the specialists or create a referral network or something like what you're suggesting. It is, but it's not anything that we're building right now. I mean, the idea that we want to be able to start with healthcare professionals, we want to be able to move that more towards, like the goal is democratization of medical knowledge, which means sharing and being able to have people not only access the knowledge they need themselves, but control what type and where they get their health care. And so this is something that I would love to see happen. There's a few steps ahead of us before we're able to sort of design something like that. But you're absolutely right that that's more or less the end game. And then we can, close all the clinics and hospitals, and then.
Not necessarily, but it could broaden the horizon for a lot of patients in the community.
Yeah.
Where they don't have that clinical
Right.
availability.
No, this type of distribution changes the way that healthcare is delivered meaningfully. Yeah.
But I'm just wondering about the legal protections. If I am providing medical knowledge, I would always have that thought at the back of my mind. Am I covered here? This is treating.
Yeah.
How are we treating or advising on treatment for patients that are outside of my own scope of practice or my own where my medical indemnity insurance does cover?
Yeah. I mean, the short answer is this is a platform for people to talk. And what that means is it's for information and education. And if you need to learn something in order to help somebody right now, you'll take that knowledge from whomever gives it to you. We want people to be able to feel freely to share information and to discuss cases, because that's the goal. And we do our best to create a safe environment for people to have those conversations. And the conversations are open and available for anybody to read and see. Rarely has it been a situation, in fact, I don't think I've ever seen a situation where somebody's come back and said, well, this wasn't right, why did you tell me that? And I think the reason is, and I don't want to be reductionist about the work that physicians do, but you don't just go to a website and be like, hey, what's the answer? Great, thanks, bye. Right? It's a more complicated, nuanced, thoughtful process where you take a piece of information from here and this and this and this, and you use your own brain. Like we always say, the doctors and nurses are the ones who are doing the actual care. You're the one who's making the diagnosis. It's not somebody else far away. They're helping you understand what it is you need to know, just as if you had called a colleague. So that's my mental model of how that is. Yeah, that's right. I mean, essentially it says that this is an informational or educational tool, and that you're in charge of looking after your own patients, which is, it has the benefit of being true, which is great.
So as an educator, I'm sure you've got a great number of HIPAA compliant images. Are we able to download them, and how do we cite them if we want to use them in educational content?
So right now, the way it works is essentially it's simply through the share process, just like any other social media sharing process. So if you want to, link to it on Twitter or Facebook or whatever, you can do that. We don't currently have support for downloading images wholesale, and that's mostly for the protection of the uploaders, because they retain ownership of their images. Some people have asked us whether or not this counts as publication, and if I publish it on FigureOne or if I put it on FigureOne, can I still publish it in a journal? So yes, you can still, of course, until FigureOne launches its journal of case reports or something like that. 100%, yeah. So essentially, when you look at the app, it's just a feed of images, and you can scroll down, all the way to the bottom if you want. There's 3 years worth of images in there, and we're serving over 5 million images a day. So yeah, you can scroll down deep, but you can also search for it, which sort of hints at the nature that, in fact, I think 1 in every 3 users is using it primarily for search. People are coming in and trying to find cases. So I know physicians who will use this so they can find examples of cases to show their colleagues. Like, oh, I saw a case like this the other day. It was, whatever, urticarial vasculitis. Here's what it looked like. Or they can say, I need to look at a bunch of cases to see if what I'm looking at in real life matches what many, many other people have seen. And so, yeah, search is definitely an important part of our